Hello everyone. Today we are going to talk about the management and prevention of venous thromboembolism, or VTE, with a particular focus on cancer-associated thrombosis and special populations like obese patients. Let's do an introductory slide first. VTE includes both deep vein thrombosis and pulmonary embolism, and it is a major cause of morbidity and mortality, especially in hospitalized and cancer patients. When managing VTE, the choice of anticoagulation depends heavily on the patient population. In cancer-associated thrombosis, recent evidence favors the use of direct oral anticoagulants, or DOACs, specifically apixaban, edoxaban, and rivaroxaban. For example, the Caravaggio trial demonstrated that apixaban is as effective as low molecular weight heparin with similar bleeding risk. The Hokusai VTE cancer and SELECT-D trials support edoxaban and rivaroxaban respectively. Historically, low molecular weight heparin was the standard due to superiority over warfarin, as shown in the CLOT trial, but now DOACs are increasingly used as first-line agents. However, in patients with gastrointestinal or genitourinary cancers with mucosal involvement, we avoid edoxaban and rivaroxaban due to increased bleeding risk. In these cases, apixaban or low molecular weight heparin is preferred. In general, DOACs are preferred over low molecular weight heparin for short-term treatment, and either option is reasonable for long-term management. For non-cancer patients, the hierarchy is more straightforward. DOACs are preferred over warfarin, which is in turn preferred over low molecular weight heparin. DOACs are going to be attractive because they don't require INR monitoring, they have fewer drug and food interactions, and they also offer convenient fixed dosing. Warfarin is still necessary in certain cases, such as patients with mechanical heart valves, severe chronic kidney disease, or antiphospholipid syndrome. Now let's go over the next slide. If a patient develops a recurrent VTE while on anticoagulation, management depends on what they are currently taking. If they are on a DOAC or warfarin, the recommendation is to switch to low molecular weight heparin. If they are already on low molecular weight heparin, we increase the dose by 25 to 33% and check an anti-10A level to ensure the therapeutic range is adequate. Now let's shift to VTE prophylaxis in cancer patients, particularly odd patients. The Corona score is a validated tool used to stratify VTE risk. It assigns points for various risk factors, including tumor type, high platelets or white blood cell counts, anemia, high BMI, and more. And a score of 2 or higher is considered high risk. In these patients, prophylactic anticoagulation with a DOAC like apixaban or rivaroxaban can be considered, as supported by the AVERT and Cassini trials. Low molecular weight heparin is also an acceptable alternative in high-risk patients. Finally, it is important to address the abuse population. According to the 2024 circulation guidelines, DOACs should generally be avoided in patients with a BMI of 45 or greater or weight of 150 kg or greater due to concerns about underdosing and reduced efficacy. In these cases, warfarin is preferred. If a DOAC is used, the ISTH 2021 guidance recommends monitoring peak and trial levels to ensure adequate drug exposure. Now let's go over this table to wrap things up. So this is going to be a useful table. It highlights the preferred anticoagulation strategies in different clinical scenarios that we just went over. Let's start with cancer-associated VTE. Both DOACs, especially apixaban and low molecular weight heparin, are considered appropriate. The shift toward DOACs is supported by recent trials like Caravaggio, but low molecular weight heparin remains a strong option, especially in complex or high-risk patients. Next, for patients with GI or GU cancers that have mucosal lesions such as colorectal or bladder cancer, the bleeding risk with edoxaban and rivaroxaban is higher. So in these cases, we prefer apixaban or low molecular weight heparin to minimize bleeding complications. If a patient has a recurrent VTE, despite being on anticoagulation, the approach depends on what they are already taking. If they are on a DOAC or warfarin, we switch to low molecular weight heparin. If they're already on low molecular weight heparin, we increase the dose by 25 to 33%, and we also check the anti-10A levels to ensure they are in the therapeutic range. For patients with general VTE and no cancer, DOACs are going to be the first line, followed by warfarin and low molecular weight heparin. Low molecular heparin is going to be used less often. Typically, it's only used in special circumstances like bridging or contraindications to oral agents. In patients with severe obesity, which is considered a BMI of 45 or more or weight of 150 kg or more, the efficacy of DOACs becomes less reliable, and so in these cases, warfarin is preferred. And if a DOAC is used anyway, we should monitor drug levels by checking peak and trough concentrations. Finally, for cancer outpatients, we use the Corona score to assess VTE risk. If the score is 2 or higher, they're going to be considered moderate to high risk. And we should consider prophylactic anticoagulation with either a DOAC like apixaban or rivaroxaban or low molecular weight heparin. So hopefully this video helps. Thank you for watching.